Trauma-informed care. It is good practice periodically to step back, reflect, and refresh our thinking on these ideas and concepts. We need to ask ourselves, how do we individually and collectively use these frameworks in how we work with persons served and with each other? In this annual review, we will be focusing on what trauma-informed practice means. In this module, we will define trauma, describe the prevalence of trauma, understand the impact of trauma, and list the fundamental principles of trauma-informed care. The 3 E's of trauma. Trauma is defined as an event or series of events that is experienced as overwhelming and has a lasting effect on the person's functioning and mental, physical, social, emotional, or spiritual well-being. Why is it important to focus on trauma? Studies have found that in the general population, 24.7% of women and 16% of men reported being sexually abused during their childhood. 27% of women and 29.9% of men reported being physically abused during their childhood. And 16.7% of women and 12.45% of men reported being emotionally neglected. In the general U.S. population, 61% of men and 51% of women reported experiencing at least one trauma in their lifetime, with witnessing a trauma, being involved in a natural disaster, and/or experiencing a life-threatening accident ranking as the most common events. People who have experienced trauma or chronic stress are significantly more likely to be diagnosed with a mental illness or substance use disorder, and are at increased risk of being incarcerated and having chronic health conditions throughout their adult lives. What percentage of clients in public behavioral health care settings have experienced trauma? 90% of clients in public behavioral health care settings have experienced trauma. Childhood experience of abuse or neglect is correlated with the development of later psychosis. True or false? True. Multiple studies have found a significant correlation between the experience of trauma and psychosis. Shevlin et al. Found that a person's experience of child abuse increases the likelihood of later psychosis 1.6 times. What is the impact of trauma? People with histories of trauma in the public mental health system have earlier first admissions, more frequent and longer hospital stays, more time in seclusion and restraint, greater likelihood of self-injury or suicide attempt, more medication use, more severe symptoms. The vast majority of people who receive public mental health services have experienced trauma, prolonged periods of chronic stress, or both. We can and should assume people have experienced trauma even if it is not documented or there is not a PTSD diagnosis. It is also very important to assume that some of our colleagues, friends, and family are also impacted by traumatic experiences. Universal precautions in this context means delivering services that are designed with this in mind. This is called trauma-informed care. Evidence is strong that trauma plays a causal role in virtually all mental health conditions. To be trauma-informed is not the same as assessing or treating trauma. The 3 R's of trauma are, first, a realization that trauma affects people, families, organizations, and communities. People's experiences and behaviors are understood in the context of coping strategies designed to survive adversity and overwhelming circumstances such as childhood sexual abuse. There is an understanding that trauma plays a role in mental and substance use disorders and should be systematically addressed in prevention, treatment, and recovery plans. Second, people and organizations are able to recognize the signs of trauma. Trauma screening and assessments are routinely done. Supervision and workforce development routinely focus on trauma. Third, people respond by integrating an understanding that the experience of traumatic events impacts all people involved directly or indirectly. People change their language and behaviors to take into consideration the experience of trauma among the people we serve. Professionals and organizations prioritize both physical and emotional safety. A trauma-informed approach resists re-traumatization of persons served and staff alike. Systems and organizations often have practices and procedures which inadvertently create stressful or toxic environments that interfere with persons served recovery and staff's well-being. Alternately, staff and organizations that implement trauma-informed practices create a sense of safety and connection for persons served and staff. Trauma-informed practice, core values continued. Choice. Activities offer persons served choices and control. Collaboration. An inclusive approach instead of a top-down hierarchical approach. Empowerment. Self-esteem and skill building. In 2015, the staff in the inpatient units at the Solomon Carter Fuller started to do some important work. They made a concerted effort to be more trauma-informed in their interactions with patients. Starting in 2015 to 2016, there was a significant decline in restraint and seclusion rates. Here is Solomon Carter Fuller's Dr. Mary Louise White to tell what they did.
So we decided that we were going to do something very innovative around trauma-informed care, specifically around safety, choice, and empowerment. So one of the things we did, we had an old room downstairs on the ground floor where when patients were admitted, the ambulance brought them, or the sheriff, sorry, brought them, and they were in their shackles, and it was an old dingy room, and they sat there and they waited, and then they were brought up to the units in shackles, and when they came to the unit, they took off the shackles and they let them off the unit. So one of the things we changed was we said we wanted the first contact with us to be a much more pleasant one. So we redecorated that space that we had. The other thing we did was to ask the supervisor to go down. Once they got the call that the patient was here, that they would go down to that space and greet the patients. So they would greet them with something like, "Welcome to the Fuller, we have been expecting you, we have a meal for you." A lot of the patients we have come from the court, they've probably been sitting in the court all day, they may not have eaten, and they've been tired. And that was a good way of making them feel safe and making them feel welcome. What are some of the outcomes of that? We noticed once we started doing that, that we had less patients attacking the staff within the first 20 days when they got here. We noticed that it also had an impact on the number of restraints that we had, as well as the number of staff who were injured by patients. As a result, a lot of the patients, when they leave or right before they leave, they say how important this first contact with us. Another thing that we did around safety was looking at who we hired. In the past, we hired people, they applied, we looked for a lot of people who had physical strength and, to make sure, they could show strength on the unit. We've been able to hire some staff who are very compassionate, who are very skilled in talking to patients, and when things are beginning to get challenging for patients, they can engage with them, and they can help prevent a very difficult situation that probably would end up in a restraint or some other aggressive behavior. And that has been very rewarding for us. In this environment, there tends to be, staff, it appears that staff has the power, and the individuals that we serve just have to obey and move and go along with what staff says. This was very, very profound And when we started making some changes around, let us let loose of some of the rules and some of the issues that caused power struggles between patients and staff. Most significant was patients wanting something. They would like a drink, some juice, some crackers, some yogurt, a snack. They wanted something. And of course, in the past, what it would be like, the patient would say, I would like a drink, and the staff says, okay, when I have a chance, I'll get it for you, I'll give it to you. And the patient is waiting, and next thing you know, they're beginning to get a little upset and agitated, and then you get into the power struggle, and sometimes, I'm ashamed to say, on occasions, it would lead to a restraint just because the patient could not get a snack at the time they wanted it. So one of the things we did, we said, you know what, why does a patient have to ask for a snack? Let's make it available to them. Outcome of that, there's been a decrease, almost an absence of struggle around patients asking for things. And that has made a tremendous difference with patients and staff. And we have seen patients, our customer service survey say that, patients, they say they feel more respected, they feel that the staff are listening to them and they're getting the things that they want and do not have to struggle for it. And we are very proud about what we've done around, working with patients and making them feel safe and empowering them, and really having a culture, trying to create a culture in which we do not re-traumatize the people we work with, but that we are supporting them and we are making them feel safe and we are making them feel empowered while they are here and we are working with them.
Take a moment to reflect on some policies and practices in your setting that reflect an example of trauma-informed care. For more information on trauma-informed care, please visit the National Center for Trauma-Informed Care.